Good day, my dear postgraduate students. I hope you have done your homework for today's class. The history was a lesion from a 4-year-old child. Before I go into the class proper, I could appreciate that there is an epithelium, an intact stratified squamous epithelium, beneath which there is the tumor. The tumor itself has got two components. There is a superficial band-like dense aggregation of the tumor cells. And lower down, it is more loose and discohesive. This is the 9th slide for Glide the Slide. The diagnosis is embryonal rhabdomyosarcoma. Before I go any further, I would like to emphasize on the word embryonal. The word embryonal means embryo-like. It is not fully formed. It is more undifferentiated or blastemal, etc. So, we are having cells with such morphology. There is a variant called the Botrytis variant in the embryonal rhabdomyosarcoma, which means grape-like. Look at this picture over here. It is a polypoidal mass, and it is covered by an intact mucosa or an epithelium. What I am seeing over here is the Nicholson's cambium layer or a dense pack of the tumor cells. They are undifferentiated. Lower down, it can be loosely cohesive, as we are seeing in the picture. So remember the word Botrytis or bunch of grapes. It commonly occurs in the children 3 to 12 years of age, rarely younger. But rhabdomyosarcoma can occur at an older age, 50, 60 years, etc. There can be defects in the R.A.S, Hedgehog pathways. It is a soft to firm infiltrative lesion. And as I told you, a grape-like clusters is a classical history. Beckwith-Wiedemann syndrome. There can be a defect in chromosome 11p15. Dicer syndrome in Dicer 1 and Gorlin syndrome, PTCH1. These are all the genetic defects that are probable. The sites of the lesion include the bladder, vagina is one of the most important sites, a classical history. Upper respiratory tract, nasopharynx, head and neck. PAX fusion is negative and the tumor lacks PAX3, FOXC01 fusion. So these are additional things that you people can go to the book and read. What I'm interested in is, so beneath the mucosa or the epithelium, there is the primitive mesenchymal cells. There is a zone of hypercellularity and then hypocellularity. Stroma is myxoid or loosely reticular. Sometimes, if you are lucky, you will be able to see elongated cytoplasm, tadpole-like cells, or the strap muscle cells. They can be spindled also. Anaplasia, multipolar mitosis can prevail. But what we actually see will be sheets of small round cells. Sometimes they are stellate or spindle shaped. Small oval nuclei can be seen. Nucleoli in all the cells are inconspicuous. And these cells with poor differentiation are called blastemal cells. And this is a classical Botrytis picture that can be there in a patient. The types of rhabdomyosarcoma include embryonal, alveolar, Botrytis, pleomorphic. The classical one, the dense Nicholson's cambium layer and overlying there is a intact epithelium. Obviously, it is not an epithelial neoplasm. This again is the fleshy to firm nature of the tumor, Botrytis, or a bunch of grape-like. Now, there are other variants of this rhabdomyosarcoma. One is the Botrytis. We will have to mention that. Second one is embryonal rhabdomyosarcoma with anaplastic features. So obviously there will be a pleomorphism or mitosis or necrosis, etc. Clear cell variant due to glycogen. And in this case, we will have to rule out a clear cell carcinoma, particularly as a metastasis from elsewhere or from any other organ. Epithelioid rhabdomyosarcoma. So these are some of the variants. Verteroid, embryonal, clear cell, epithelial. Spindle cell and sclerosing, although given as a variant, they say it differs from embryonal rhabdomyosarcoma. This class is restricted only to embryonal RMS. Now, what are the salient points of it? It is a primitive pediatric soft tissue sarcoma from the skeletal muscle. Primitive mesenchymal cell is the cell of origin. Occurs in young children less than 6 years, maybe as low as 4 years. Of the EMS, embryonal is 60%, alveolar 20%, pleomorphic is 10%, sclerosing another 10%. Survival improved due to interprofessional management between the surgeon, the oncologist, the pathologist, and what. So this is a little different. I am able to see a good number of these trap cells. See, it is almost rectangular, elongated with the nucleus in one side, but still there is pleomorphism. Some cells are having abundant cytoplasm. Some are binucleated. Some are oval. Oval to round rhabdomyoblasts and eosinophilic cytoplasm. And this again is another one. I am finding a relatively acellular area and a dense cellular area. This can be something like a lymphocyte, but I find that the nucleus of the tumor cells are usually larger. That is the trick of it. Though there is something called a small cell carcinoma, the nucleus will be at least twice the size of a lymphocyte. And it is yet small. Anaplastic rhabdomyosarcoma, extremely hyperchromatic nuclei, more than 3 times than the adjacent tumor cells. Look at this one. These are also there, but these are looking much larger. And they are undifferentiated, which means I cannot say what its origin is. Round to spindle shape. And sometimes there can be multinucleated giant cells, as we are seeing over here, or in this case. There are many nuclei together forming the giant cell, thanks to AFI. The differential diagnosis for the blastemal tumors will be: one is Ewing sarcoma or a primitive neuroectodermal tumor, neuroblastoma, infiltration with leukemia or lymphoma, Wilms tumor. These are some of the differential diagnoses, and age and clinical history will be important. Now, this is just a question that has been given, and it is about an 18-year-old boy with a rapidly growing mass of the right hand, which was resected, and it was fleshy gray. Histology showed small round blue cells. The cells are arranged in nests, aggregates, separated by slender fibrous septae. Pseudoalveolar spaces were seen. Cystic changes were seen. Mitosis and necrosis was also present. And your diagnosis is this. I would like you to choose the correct diagnosis. Please go through. This is from pathology outlines. And this again, which histological feature is embryonal rhabdomyosarcoma needed to diagnose anaplasia? For anaplasia, which of this is most important? So kindly make a diagnosis. Go to your books. As I told you, the slide will take us to the, and these are the references, a beautiful one. And Ackerman, surgical pathology is my gold standard. Glide to next slide. And in this case, we are seeing a 15-year-old boy presenting with vesicular lesions. The slide is put up there. What is your diagnosis? What can be the procedure for diagnosis? And is there any other application of that procedure? See you in next class. Thank you.